Hello, happy Friday, everyone. Welcome to Live and On Call. My name is Allie, and as always, I am your host for today's discussion. If this is your first time joining us on a Live and On Call, just know that this is a live streamed interactive conversation where we bring Lake Charles Memorial physicians live and on call right to your computer, your tablet, your phone, or wherever you are viewing this video. Today, I will be asking some questions to our guests, and then we'll leave some time for you to answer some questions, or for you to ask some questions to be answered. So during the chat, if something comes to mind, feel free to drop them in the comment section below. And if you prefer to stay anonymous with your question, that's totally fine. You can send us a direct message during the video, and we'll be checking those as well. But don't be afraid to ask questions. That's why we're here. Live and On Call is a program for you to ask questions in a really safe environment, a convenient way. And it's about providing you with everything you need to know to make the best healthcare decisions for you and for your family. So today we're going to get started. We're going to meet today's guest, Dr. Alan Hinton. He is a board certified and fellowship trained orthopedic surgeon with Lake Charles Memorial. Let me just bring him up on the screen right here. Dr. Hinton, how are you?
I'm doing well, Allie. Good to see you.
You too. Thanks for joining us today. Do you mind go ahead and kicking us off a little bit? Share with us a little bit about your background, maybe what led you to this point, maybe what led you to becoming an orthopedic?
Sure. Well, I'm originally from Lake Charles. I grew up here, and so is my wife, Bridget. In fact, we were both born at Memorial Hospital. Can you believe that? And I finished high school here, and so did she, and I went to McNeese. I'm a cowboy at heart. And then we both, what's that?
Go Pokes.
Yeah, go Pokes. Graduated from McNeese, and then we moved to New Orleans, where I started medical school at Louisiana State University in New Orleans. After that, I did 5 years of work as an orthopedic surgery resident in New Orleans. So I spent about 9 years in New Orleans, and then an extra year up at the University of Pennsylvania doing some sports medicine work, where I had the opportunity to work with the university sports teams, the Drexel University sports team, and I was one of the assistants to the head physician for the Philadelphia Eagles. That was an interesting time back in
Wow, how
2005.
fun.
Yeah, it was fun, different.
Great.
So yeah, I kind of liked orthopedic surgeries. We're the kind of the mechanics, if you will, of the body. We work on bones and joints and tendons and muscles, that sort of thing.
Awesome. Cool deal. Well, as we get started, I wanted to talk a little bit. Today, we're going to focus in on knee pain and knee replacement. And so for those of people who are watching that may be constantly dealing with the severe knee pain and haven't found relief through conventional treatments, they might be wondering if it's time for a knee replacement. Could we start there and tell us a little bit about what is a total knee replacement? What does that mean for the patient?
Sure. Well, the knee is one of the largest joints in the body. It is the largest joint in the body, and it undergoes a lot of stress. And just because of the way we're made, the body doesn't last forever. I guess all our parts would eventually wear out. But because of genetics and maybe micro trauma or sometimes big time trauma, the knee will wear out. And what that means is, if you look at the knee, I happen to have one here, of course, the surface of the knee is coated with this cartilage, which is a very smooth, cushiony surface that allows the joint to move without pain. So when that wears out, that's typically what we refer to as arthritis. That can cause pain and swelling. Sometimes the knee feels like it wants to buckle on you. It can pop and catch and grind. So we do a lot of things to help with the symptoms. We do injections, we do medications, we'll recommend creams and rubs for the knee. Sometimes we'll actually send the patient to therapy. And all those things work really well for a while. What's going on is they're treating the symptom, they're treating the pain by reducing the inflammation down to where it's tolerable. Mm-hmm. Fortunately, the knee will continue to deteriorate once that arthritis has started. It's kind of like the tire, your tread on your tires, it wears out, it just keeps wearing out. So the only way to really get rid of the problem is to remove the surface of the bone, and where you're actually removing the arthritic condition, and you put a metal cap on the end of each of the major bones in the knee and then a plastic bushing in between. I have one here.
Conveniently,
Like this.
model here.
There's a
Perfect.
we only remove about a quarter to half inch of bone in this area, and then this bushing goes in between. And it's made of a very special plastic. It's called ultra high density molecular weight polyethylene. And believe it or not, about 90% of the polyethylene in the United States is made right across the river over there in Westlake. And they ship this up to Warsaw, Indiana, where they manufacture the actual implant.
And so we have some homegrown plastic in our knee replacements here in St. Charles, right?
Probably so, So the thing about a knee replacement, it is a rather big surgery, but it can restore function to the leg. A lot of people get around pretty well. That reduces the symptoms dramatically. And they've made a lot of improvements since I started doing this surgery 30 years ago. Before we keep people in the hospital for well over a week. And now we send some of them home the same day. Yeah. And the way we put the knee in now, it's strong and stable. It can handle the weight, and people can walk on it almost right away. And they're using a walker for the first few weeks, but after a while, they're able to get off the walker and walk around on their own.
Yeah. So Dr. Hinton, there's a few options out there now. We have this new robotic-assisted technology that's rather new in the industry for knee replacements, at least. What's the difference, in your opinion, of the robotic-assisted knee replacements and your traditional knee replacements?
Yeah, that's a great question. So what we're really looking for with a knee replacement, the holy grail, if you will, is a knee replacement where someone who's had the surgery literally forgets they've ever had it done, and they're just getting along with their life, putting everything behind them. Most of the time, that's what happens. Better than 50, 60% of the time, people who have a regular knee replacement, they just go about their business, kind of forget they ever had it done. And there's some folks who will still have some little aches and pains, and they'll not do quite as well as we'd like. So what the robotic knee is able to do is able to allow you to customize exactly the angles and the millimeters here and there of how to orient the knee, the artificial knee, when you put it in the body. Not every knee is the same. Some people are born with their knees a little bow-legged. Some people are born a little bit knock-kneed. Some people have a little bit different shape. And the implants are really almost the same. The difference is this robot lets you put those implants in what we hope to be the most comfortable position for the patient. It's really an interesting procedure. When you start the procedure, we typically do these under spinal, that way patients don't have all the typical problems we used to have with general anesthesia where they're having nausea and vomiting. I rarely see that anymore. Plus, when they wake up, they're not having pain. The block is still working, so they're awake and they're looking around. They're able to, when it wears off, they're able to handle the pain better with lower power pain medications, so we don't get all the usual complications like delirium or constipation, that sort of thing. So they get them up and walk. So when we do a robot knee, it starts off just like a regular knee replacement. We open the knee, and the difference is we are able to map the knee intraoperatively. We use a series of what they call arrays, and there's a gigantic beam or bar that has some, looks like eyeballs on it, and it can see those arrays, and it feeds that information back to the computer, and the computer makes a 3D model of the leg in its software.
Wow. Okay? All right.
Yeah, it's pretty neat. It's what makes this model of the knee inside the software. So then when I'm doing a regular knee, I'd say, okay, we're going to cut this knee this way, based on my preoperative plan, kind of what I'm guessing it to be. And then we put the knee in, and then we make a few adjustments to make the knee fit just perfect. Well, this thing, when you put the knee in, all those adjustments are already made for you. And you put the knee in, and it seems to fit really well. So I don't have to do any more adjustments. It's kind of those adjustments can slow down the progress for someone who's had the surgery also, because you're making these adjustments on the ligament to make the knee fit just perfectly so that it doesn't do this or that. You want it to go nice and smooth. You don't want it to rock back and forth.
Sure. So it's really personalized per the anatomy of the person, is what I'm hearing you say. And
Yeah, I think that's a good way to put it.
Mhm.
The artificial knees, they're very, very strong and very stable, and there's a pretty intense manufacturing process for them. And they come there's probably 10 different sizes, including rights and lefts. And these little plastic pieces, they vary in thickness by 1 millimeter, starting at about 5, and they go up to 20 millimeters. So there's a lot of inventory we have for different size variation of a knee. So we kind of got the sizes covered. It's really the nuances of the positioning that we're working on. And that's it. That's the holy grail of having a knee replacement, is that person just forgets they had it. I mean,
get back to what
one of my favorite things to tell patients is someone's going to ask you, who did your knee? And they're going to say, oh, some old doctor. Hopefully me, I guess. But so they don't, they just totally forget about having the procedure, totally forget about having the artificial knee. They're living their life as they wanted to before they had the arthritic problem.
Yeah. Yeah. So we at Memorial, we use a system called VELYS, and you were a huge advocate for this technology. What is it about this that you're so passionate about? Why are you passionate about it?
Well, there's several different robots out there. Each one has a little nuance to it. Mm-hmm. And they work almost kind of the same. This one I particularly prefer because we don't have to do a bunch of special CAT scans or expensive MRI scans of the knee beforehand. You're doing it live. You're on the knee at that moment, mapping it out. I mean, I think I trust that better than a CAT scan or an MRI scan, because those things can be, they tell you what the bone looks like, but they don't really assess the ligaments. And that's where the key, in my mind, the key is when you're doing this particular procedure, because you can stress the knee and move it around, and that computer can see where it's loose and where it's not loose, and it can help you make those adjustments in the way you put the knee in place.
Gotcha. Well, just a quick reminder to those of you who are watching, if you have any questions, feel free to put them in the comment section below. We'll get to those in just a second, but I do have a few more questions for you, Dr. Hinton. For those that are watching, they may not be sure if a knee replacement is the next step. What advice do you have for people that are kind of weighing their options? How do they gauge when it's time to explore that?
Well, first of all, there's a million things that can cause your knee to hurt. It can be torn cartilage, it could be a ligament injury, it could just be inflammation. So proper evaluation by your family doctor or by your orthopedic surgeon. Typical way we would evaluate a knee for arthritis would just do a simple set of x-rays. I mean, x-rays have been around since the 1800s, right? It's old-fashioned technology, but it still gives you a lot of information about the condition of the bone. And you can see if that cushion is deteriorated, it'll be just, really close to sometimes even bone on bone when you look at the femoral condyle and the tibia. That's really the simplest way. And you can tell if it's arthritic. Sometimes you can also tell if there's a lot of deformity, which can alter the way you approach the problem. Braces can be sometimes helpful, and simple things like cortisone injections or even medication or therapy. Sometimes that's all that's needed. Now, every once in a while you run into a little bit more complex case where somebody's having some knee pain that's not evident on the x-ray. X-ray looks fine. Then you might need an MRI scan to help tell you if there's a cartilage injury or something else going on inside the knee.
Gotcha. So you talked about this a little bit earlier, but the recovery time for a patient, what's required after the knee replacement? How long does it typically take to recover?
Oh man, I've been doing this for 30 years. I can tell you there's not really a cookbook answer to it. But I guess if I had to give you one, I'd say that, like I've said before, most people are walking around with a walker at about getting off the walker about 3 weeks. And they'll limp into the office maybe with a cane or a crutch, or sometimes without. My favorite patient is my elderly females. They do fantastic. I mean, you get those 70-year-olds, they walk in with carrying the walker like it's nothing to it. Most people, after about 6 weeks to 2 months, they're getting around pretty good, and like I said earlier, I've done bunches of these things, and I'll do one knee and I'll do the same thing to the other knee. And they say, this one took longer to get over than this one. It's the exact same surgery, but whatever. Ultimately, have faith. They almost always turn out okay. It's very rare to see one not eventually turn the corner and be okay.
Yeah. Is there physical therapy that's required for a good bit after this, or is it kind of?
Yeah, everyone's a little different. I love the therapists. I mean, I have a great relationship with the ones at Memorial and across the town. Used them for years. When someone has a knee replacement, it's kind of a big surgery. And if you ask them, hey, what was bad about the surgery? Sometimes they'll say therapy. So I usually don't try to send them to therapists right away. I let the leg kind of calm down, let them kind of move at their own pace. And then when I see them back in my office in 2 to 3 weeks after surgery, then we kind of make a joint determination about how much more therapy we need. Sometimes they're a little slow getting the range of motion, or they're still feeling a little timid about putting weight on it. I'll send them to a therapist, and this can be reassuring for the patient to have that person see them so frequently, and they can see other people in the office and see how they're doing.
Yeah. Yeah, I got you. They don't feel always that they're doing that recovery on their own, potentially.
Yeah.
So I have one more question. Again, if you guys have questions, go ahead and drop them in the comments below. But I wanted to ask you, Dr. Hinton, is there a particular success story that you're proud of? Maybe any kind of situation that you saw throughout your career that you've been really proud of?
There have been a lot of. I'm fortunate. I've been around for a long time, and I try to find success as often as I can, and it's very. I mean, yeah, we have bigger cases here and there, but it's touching when a patient tells you how much better they're feeling than before surgery. In fact, just this morning, a patient who had a problem with her knee. I mean, she's single, having trouble getting around, and it can be very, very debilitating when someone has an arthritic condition in the knee. They can really drag you down. In fact, it drags the whole body down. And she made a very successful recovery, very happy, pain-free, doing fine. And so that was not a tough case per se, but it's very rewarding. Which kind of brings up another point. Years and years ago, we used to tell people, don't have your total knee until you're, can't stand it any longer. And that was probably not great advice. Because what we found out is that people were putting it off and putting it off and putting it off until they're very elderly. And then they come into your office with a big old Walmart bag full of pills. And it makes it very difficult for them to recover from the surgery. They've been struggling for years, having the pain when probably could have had it done 4 or 5 years earlier, made a quicker, better recovery, and not be such high risk with all the medications they're on as we get older. Unfortunately, as we get older, we don't get healthier.
Yeah. So whenever you start to have those thoughts of what's going on with my knee, why is it hurting so bad? Maybe it is time, as soon as you start feeling that, to start getting that checked out by primary care doctor, seeing if you need a referral, that kind of thing.
Well, like I said, if someone's having some knee pain and not sure what's going on, it can be fine to take a little Tylenol or ibuprofen, or maybe try a little brace on your own. But eventually, if it persists, it's probably not a bad idea to at least get some x-rays. And we always recommend that you get an x-ray for a knee with it standing, because that way, if you're not standing, then it might show there's some cushion left. And if you stand in it, it pushes down your weight, and it'll bring that bone together. You can see it and make the diagnosis a little bit easier, a little bit more accurate.
Interesting. I wouldn't have thought about that. That's a great point. That's awesome. So I think we have one comment for sure. Question. It says, do you have any tips on how we can take care of our knees and joints to delay pain or surgery?
Oh man, I'm glad you said that. As I said earlier, the human body is not made to last forever. So you kind of got to be a little bit more careful with your body. I was a giant proponent of jogging when I was younger. And I jogged and ran marathons and did all that stuff. And now my knees are all wore out. I should have listened to my grandmother tell me not to do all that stuff. Yeah. But, when you're that age, you're going to do it anyway. So my recommendation, if you're working out, is great, but probably should be low impact. rowing or swimming or biking or Stairmaster. Those are really good workouts that help your muscles. Weight training is actually a very good exercise for your body and your knees. Weight training with weights will help build the calcium up in your bones and help prevent osteoporosis. It's really good for the muscles. So light weights, high repetition, that's a really good way to go with working out. And then some aerobic type activities that's a little bit lower impact. Swimming is the best, but it's so boring. I mean, it can be tough. You're staring at the bottom of that pool for minutes at a time and begging to get to the other side of the wall to catch your breath. But if you know how to swim and swim good, it's a great exercise.
That's awesome. So some low impact, focus on low impact exercise to kind of take care of your joints as you age.
Yeah, there's the exercise where you're jumping around, what they call plyometrics.
Yeah,
that can kind of wear on you, and the constant pounding of jogging, it's probably not the best for you.
Gotcha. Awesome. Well, I'm not seeing any more questions here in the comments, but if you guys that are watching, if you think of something after the video, after the live stream's over, feel free to drop them in there, and I'll get with Dr. Hinton, and we'll be able to get you an answer to that as well. So is there anything else you want to add before we wrap up, Dr. Hinton? Any other conditions, total joint replacements that you're passionate about?
Yeah, I mean, I do quite a bit of joint replacement surgery now. In the first 10 years of my practice, I did a lot of trauma. And the second 10 years of my practice, I did bunches and bunches of sports medicine stuff. But fortunately, they had a bunch of new guys come to town who were all gung-ho to do that and go to all the football games. And so they took over. So I've been doing more and more joint replacement surgeries, and it's been good. It's a very rewarding field. So there's almost every joint can be replaced. I don't know if you know that, but we got a lot of them out there. The knee is just one of the most common joint to be replaced. I probably average well over 200 of those a year. And I do a fair amount of hip replacement surgeries, and just a little over 100 a year of those. So that's an extremely common procedure. Very, very common. In fact, my wife had her hip replaced, and I didn't do the surgery, I promise you. I may not be the sharpest tag, but I ain't doing that. But, she did fine. She got off her walker and runs around now and just has no problems at all. Hip surgery is the easiest one to get over. It's an amazing procedure. That's by far the most common one I do, and send patients home the same day.
Wow.
Shoulder replacements, probably number 2 on the get over margin, and knees are a little bit tougher. That was kind of a tougher one. And if you think about it, you're putting all that weight on your knee, and you have to bend it. It bends back and forth. You think it bends like a hinge, but it doesn't really bend like a hinge. It has more of a cam shape to the femur. So you have to be real careful when you put those things in. And fortunately, it works out.
Awesome. Well, I did see one more question come through, so I'll ask you this question before we go. Somebody's asking, can we ride a bicycle after surgery? So I guess
activities after surgery. That's a good question. So I've been doing this. I act like I'm I've been doing it forever. Seems like we used to give patients all sorts of do's and don'ts. And every one of them I've ever had would go out and do exactly what I told them not to do, and they come back and brag about it. You said don't drive my tractor. Well, I drive my tractor. You told me not to run on my leg. I run on it. So we tell them these things because we want that artificial joint to last forever. We don't want them to have another surgery. We don't want to see them damaged. So again, low impact activities is what we'd recommend for someone after they've had an artificial joint replacement. You can go back to sports, but like doubles tennis, that's an excellent. Ballroom dancing is an excellent activity to do. Biking is fine. And remember, it's not the biking that causes the problem. It's the fall when you fall off a bicycle. So be careful with that. Stationary bike is definitely safer rather than a road bike. Swimming is fine. Rowing is fine. All those types of activities that you can get your heart rate up really do help. Another easy way to get your heart rate up is sauna. That's a very good exercise. Skin is you're not exercising, but you're getting your heart rate up. The skin is the largest organ in the body. doing the sauna where you're getting your sweat up and you can stand it for 20 or 30 minutes at a reasonable temperature. Really does help out your cardiovascular system.
Awesome.
Yeah, the Swedes have been doing that for years. Yeah.
All right. Well, I think that about wraps it up. I really appreciate you visiting with me today and going through some of these questions. And I think the main message I'm going to take away from today is that if someone's living with knee pain, explore your options. And I think I could probably speak for all of us here at Memorial that we want to offer the opportunity for people to get back to what they love. And so that's why we offer really cool, amazing surgeries like the robotic-assisted knee replacements. So again, if you guys have any more questions, you're welcome to put them in the comments. But we're going to go, and Dr. Hinton's information about his office is on the bottom of the screen. So if you would like to make an appointment or ask your primary care doctor about getting an appointment with Dr. Hinton, we'd truly appreciate it.
Well, Allie, thank you for your time. It's exciting to have this type of technology available at the hospital. Most of the orthopedic surgeons working there all use this robot. It's not just me. There's Dr. Cohen, Dr. Cryer, Dr. Jackson, Dr. Henry. So it's available with all the orthopedic surgeons. And it's a great technology. Very happy to offer it to patients. Well, that's what we want. Someone who has this surgery, unlike most diseases, you got to keep taking pills and treating it the rest of your life. You had this arthritis, you have the surgery. We want you to forget about that joint and go back to your business and live a normal, healthy life.
That's right. All righty. Well, we'll see you guys next time. All of the past episodes are available on our YouTube channel if you'd like to learn more. If you enjoyed this episode, we have information about therapeutic Botox, cancer prevention, healthy eating, all of those things, and they're all available on our YouTube channel. So we'll see you guys next time. Thanks, Dr. Hinton. Have a great day.
Thank you. Bye-bye.